Good evening and welcome to my YouTube channel, Pain Free Partner. You can also visit my website, www.painfreepartner.com, and you can download the slides all free of cost. You can edit and you can present. That is the advantage given in the slides, as it is freely downloadable from www.painfreepartner.com. So today's topic is about pregnancy and anemia. There are certain evidence-based slides and certain slides which I want to stress like points. So what is this anemia like? Anemia is a qualitative or a quantitative? This is what we should understand. Just because it is 6 grams, just because it is 8 grams, just because it is 10 grams, that is quantitative. It may be qualitative. The hemoglobin is not good. So that is what is anemia. Some other defect, resulting in reduced oxygen carrying capacity of the blood to the vital organs and tissues. This is what is anemia is about. If you go, let us start into anemia and pregnancy, because if you go on starting about anemia, that's a different topic. So they say 11 grams is okay for first and third trimester and 10 to 10.5 in the second trimester. So we can say 10 grams in India. Now you say WHO, the prevalence of anemia is around 56% in pregnancy. See here, 1 in 2 is anemic. In India, the incidence is around 40 to 80%. We did a nurse study there, 95% were below 9 grams. Now this is our study of hemoglobin prevalence of anemia in more than around 300 patients. Here you can see the hemoglobin is average is 9.75. And anemia percentage is almost 1 in 2, 50%. Okay, now why we should be worried about anemia and pregnancy and anesthesia, anemia and pregnancy? So we can have maternal problems because anemia can cause poor weight gain. They can go to CCF, they can go to PAH, they can go to dysfunctional labor, PROM, etc. Premature rupture of membranes. They can go for subinvolution and sepsis. They go for little more bleeding. So all these things, PPH, PAH, CCF, all these things, they are more prone for. This is about the mother. In the fetus, there can be prematurity, low birth weight, poor Apgar scores, fetal distress. They can go for neonatal distress, requiring prolonged resuscitation. These are the problems. Now, anemia is qualitative and quantitative reduction. Hemoglobin is less than 10 grams. Usually, second trimester is slightly less. Mother can have CCF, PH, bleeding, PROM, etc. Fetus can have prematurity, low birth weight, poor Apgar scores. They need more time for resuscitations. This is a very simple calcium content case, oxygen content, hemoglobin into 1.34 into saturation into 0.003 into arterial pivot. Now, if the hemoglobin is 15, your content is 9.8. If the hemoglobin is 5, the content is 6.7. This is what we should understand. Hemoglobin's importance in oxygen. There are a lot of classifications. That's what I used to tell. Mild, moderate, severe, very severe. 9 to 11, 7 to 9. Here you can say 11 is more than 11 is normal. Here mostly around. So 7 to 9, 4 to 7, less than 4. Some people say 6 to 8, 8 to 10, less than 6. So these are all the things which are slightly different in guidelines. Now, physiological anemia of pregnancy required nutritional iron deficiency, folate, and B12. Only 3 things to form hemoglobin now: iron, folate, B12. Infections, malaria, worm infestations, hemorrhagic, bone marrow suppressions, renal disease, genetic like hemoglobinopathies, thalassemias, etc. Now, if you want to go this way, it is physiological anemia of pregnancy, and we can have acquired anemia. It is hemorrhagic, nutritional, and hemolytic. There may be acute blood loss or chronic blood loss. There may be a bleeding piles. There may be hookworms. Iron deficiency anemia, macrocytic anemia. Diamorphic means both microcytic and macrocytic is there. Hemolytic anemia, there are so many things. Hemoglobinopathies, malarial infestations, drug reactions, etc. Now we can say this iron deficiency, macrocytic is only different in this. All others are normocytic, normochromic anemia. Iron deficiency is microcytic. B12 folate deficiency may be macrocytic. There may be dimorphic anemias. So all others are normocytic, normochromic anemias. Now we will go straight into the maternal changes because continues to rise blood volume, plasma volume, RBC also increases. But you see here increases 45 to 50, here is 30 to 35 RBC. That is why the plasma volume increase is more than RBC increase. That is why there is a physiological anemia, but never it is 15% decrease. So for example, if the antenatal hemoglobin is and it goes beyond below 8.5, that is 15%, then there is definitely anemia. It is not physiological anemia. It is likely to decrease from 10 to 9, that is 10%. Not beyond 15%, that is 8.5. Lot of compensatory factors. Now you can see increased cardiac output. If it is more than 10 liters, then maybe CCF. Increased 2-3 DPG levels. Curve is shifted to the right. Decreased blood viscosity, microcirculations and better oxygenation, release of renal erythropoietin. So if you have anemia, you can have blood viscosity decrease, you can have cardiac output increase, you can have 2-3 DPG increase, and you can have erythropoietin increase. So these are all the A. If you get A, you can have B, C, D, and E. Now we can see there is a small hitch here. Cardiovascular changes in anemia. You can see the cardiac output increases, SVR decreases. All these things also happen in pregnancy. So these plus this too is dangerous. So because there are a lot of cardiovascular changes in pregnancy, there are a lot of cardiovascular changes in anemia. Because pregnancy increases heart rate, anemia increases heart rate. Pregnancy increases cardiac output, anemia. So these, when there is a problem here, if there is an addition, think of the danger. So this is a maternal hemoglobin and this is an anemic individual. We can also see the plasma proteins normally increases. If the albumin falls, you can have edema. If the protein bound drugs. All these are problems of normal pregnancy, and this may be exaggerated by further dilution in anemia. Again, there is maybe problems in coagulations. What are the signs and symptoms of anemia? Mostly it is vague because even if the uterus comes up, they may be feeling dyspnea. So body ache, fatigue, loss of appetite, digestive upset, breathlessness, palpitation, all these may be there, even there is no anemia. This is what is important. Go to pallor, nails, tongue, conjunctiva. If there are neck full veins, mild edema is there. See the pulse because tachycardia and wide pulse pressure may be a normal pregnancy sign. So it is usually, in my experience, whatever be the tachycardia, due to a pregnancy, it usually doesn't cross around 100. Around 100, maybe 102, 103. That is what is maximum it takes. If it is going to be 115, then it is dangerous. Hyperdynamic apex beat and some flow murmurs. Now, why should there be such a problem? Because they need this, and we cannot have sometimes in vegetarian diet so much. That is the problem. So we may need to have some supplements. For example, some 60 milligram of elemental iron plus 500 mics of folic acid for 100 days. So this may be slightly enough for these patients. Now we have found out this is a pregnancy with anemia. Complete bed rest if it is going to be severe anemia. and maybe proper position because they may go into congestive heart failure if they lie down. Oxygen supplementation, some sedation. So diuretics because there are a lot of problems in patients. Already there is a lot of changes of cardiac output and blood volume. Packed cells. In packed cells, the low 2-3 dpg level may again. Now what we are giving for? We are giving the hemoglobin blood cells for oxygen. If we are giving a hemoglobin where the 2-3 dpg is less, then again it may not be useful for which we are giving for. That is what we should understand. It may take time. After stabilization, we can go to parenteral ions. Oral ion may be given in mild cases. 100 milligram first line diagnostic. Very simple. Don't do a lot of tests. You start oral ion, 100 milligrams. You elemental ion. So you start giving some form of ion orally 2 times a day for 2 weeks. There should be a hemoglobin increase of 1 gram. This is a significant sign of iron deficiency anemia. No other test is needed. Give iron, hemoglobin picks up by 1 gram in 2 weeks. Yes, that's it. Needs to be continued post-op, postpartum. Now, if there is some problem in digestion, or if the patient develops some gastrointestinal reactions to oral iron, or sometimes they may need parenteral iron. So there are a lot of iron dextran was there, so many things. Total dose Infuran was there, and iron sucrose, carboxymaltose, derizymaltose, all have come with the difference between this is around 100 rupees, this is around 2000 rupees. Total dose is body weight into target hemoglobin minus into 2.4. Now, if the patient is 60 kg, now we have a target of 12 and the actual is 8, 4. So 60 into 4, 240 into 2.4. So we may need around 600, 700 milligrams. So we may need around, followed by 10 milligram of kg. Some are needed only twice a week. Some hemoglobin IV, see iron hemoglobin IV are needed only twice a week. So 10 milligram per kg to replenish the iron stores. Yes, you may have pain at the site of injection. There may be body ache and joint aches. Very common, especially after 2 days. Some patients usually prescribe paracetamol, 1 TDS. From first day you take because arthralgia may be there. Anaphylaxis and allergic reactions. There may be nausea, vomiting, headache, dizziness, even seizures, wheezing, dyspnea, respiratory. Those are very uncommon towards these things. So most common is a small allergic reactions. On that side, myalgia, arthralgia. So major reactions are less common, but still, and is admitted. Patients are admitted under ICU, whatever the care is, under inpatient care only they are given. Now we know how to cover this. We have given less than 6 grams blood, and around 7, 8, 9 we have checked about giving iron and picked up these things to hemoglobin to target hemoglobin minus to like. On the history, we should take whether the history of any blood loss is there. Bleeding from GIT, bleeding from genital tract itself, or there may be pains, or there may be a nutritional problem. So history of prior transfusions. So this is about. So I can see many patients getting heparin and aspirin in these patients. So go into the history of antenatal. Heparin, aspirin, any other drug the patient is getting, there may be a bleeding inside or piles may be bleeding because these type of engorged pile masses are common in pregnancy. Go into the details because they may not say as it is important. Just pick up a thyroid disease. Already we have started with pre-operative assessment as history. Clinical signs. Clinical signs is see the pulse rate, see the diastolic blood pressure. It will come down maximum around 50 millimeters. If it comes below the stochastic, yes, these are small things. Go into the pallor of navis, cornea, cystoclera and all. So then you go to CVS, RS, pulmonary edema, everything. And go into a complete hemogram, reticulocyte count, peripheral smear, a microcytic hypochromic, or a macrocytic, or a normocytic. Normocytic means there may be hemolysis. There may be some splenomegaly. All these things we should think before going into giving anything. Renal function test, because there may be a mild renal problem which is going for anemia. Serum ferritin, a stable glycoprotein, most reliable indicator of iron stores. Less than 15 or less than 30, what is that level which we have to think that it is dangerous or view that iron is different. Acute phase reactant, some other disease comes, ferritin will increase. Another marker of iron is transferrin saturation, less than 16% or less than 20%. So there are a lot of other markers like hepcidin, soluble transferrin, and erythropoietin. That more important is clinical rather than echo and all, because already in pregnancy there may be a lot of echo changes. And anemia in pregnancy there may be echo changes. So yes, we have to keep it in mind, but they are not that much pushing towards what treatment is going to have. The basic assessment does not change. Just because the patient is having anemia and pregnancy, you need to put where we can do spinal, where we can get an IV access or not, where there is any other history of surgical or history is there or not. Assessment of airway. These don't change. Do we need to transfuse pre-op? It should be more than 10, preferable no transfusion. Less than 6, yes. Think. 7, 8, 9, decide on surgery, clinical conditions, urgency, if there is an ongoing bleed or a threat bleed. So it should be clinical. Should there be a symptom-based transfusion? For example, 7 to 8 grams is there. Patient is symptomatic. Or no, I'm not in favor of 8.5. The hemoglobin is fine. Should there be a hemoglobin-based transfusion? Is controversial. Moderate anemia, this is what I have told. Diastolic blood pressure more than, pulse rate 100. This is what I told. Coexisting conditions is none. Tachypnea is absent. Urine output is normal. So these things, if you go for LSCS, they don't precipitate decompensation. All these things are just acceptable. Labor epidural is beneficial in the first stage with supplement of oxygen. Sometimes you may need to give steroids for maturity, lungs, digitalization, diuretics, CPAP if signs of pulmonary edema exist. The second stage should be curtailed because you should not becomes very painful. All these things they will land up in acute cardiac decompensation. So assisted delivery. Active management with utrotonics and tranexamic acid prevent PPH. Start initially. As soon as the head comes, start giving oxytocin hormone. Actively managed with utrotonics. What is the choice of anesthesia? It doesn't matter. You have to avoid hypoxia, maintain the FiO2 high, maintain cardiac output, maintain the oxygen dissociation. Because if you cause hypercapnia or hypocapnia, then it will start ventilating like this. Then in ODC is going to shift. If your temperature is less, the ODC is going to shift. So preferably no sugar. So what is your experience on anemia and pregnancy? So for some people, I'm very experienced in spine anesthesia. I'm very experienced in segmental epidural. I'm very experienced on put an epidural catheter and giving shots. So what is your experience? I am giving just what that you will like. So this is important. But assessment of airway in pregnancy is important because airway problem and some amount of hypoxia is going to be very critical in these patients of anemia. So these are all the goals. RSI, ODC, hypoxia, good pain relief. Routine monitoring includes blood loss, but usually when somebody is asked, even candidates tell in examination like this, pulse oximetry, all these things, but blood loss is usually forgotten. So we may need to include blood loss in a routine monitoring, and very important in pregnant patients and very, very important in patients with anemia and pregnancy. So placenta previa, placenta accreta, cardiovascular diseases, these patients start on invasive lines. So otherwise, it's not needed. Good, these patients, yes, because they may go into a lot of hemorrhage. Easily they will bleed 2.5 to 3 liters. We should be aware of it. Aortocaval compression is a must. That doesn't change. Thiopentone, little less dose. Volatile agents, we know. Scoline, we know. Preoxygenation, little extended. FiO2, little more. Even if we need to give postoperative oxygen, avoid hyperventilation. In the postoperative period, yes, good pain relief. Oxygen, no shivering. So, because we are dealing, already I have told, 15 grams hemoglobin means 20 ml calcium, oxygen content. If we have 5 grams, it is only 6.7 ml. So we may need to give. If you produce shivering, think of it. Regional anesthesia, preloading is required, and patient has to deal with auto transfusion after delivery. After the delivery, immediately paracetamol will be thrown out into the circulation. We should be ready because decompensation may precipitate. Just be ready with some diuretics. Aortocaval compression, yes, ready with manual displacement. Vasopressors are required, use phenylephrine because there is no tachycardia. So prefer to use some amount of vasopressors, phenylephrine, rather than pushing the fluids like this. Head down tilt, yes, preferably only the legs up, and you are strapping the legs. Oxygen administration should be continued postoperatively. Lung signs, tachypnea, diaphragms. Sedation is very difficult because some people or some pediatricians are very particular what was given in the preoperative. So some mild amount of midazolam is okay. This is what I use. Mild midazolam, 1 milligram or something like that. Patience and fluid warming devices to prevent fall in core temperature. Shivering. Good analgesic plan to prevent postoperative pain. Neuroendocrine responses because they may be bleeding one form. So ketorolac, diclofenac, questionable. So IV paracetamol is fine, IV tramadol is fine, and narcotics intrathecal is also okay. But we should be careful about what is happening in the postoperative period about hypoxia. That drug was extensively used. Slowly it is decreased on the decrease. Aggressive replacement is needed. 6 grams, that's what I have told. 6, yes. 7, 8, clinical basis. 9, 10, generally not needed. 7 to 8 grams transfusion should be considered cardiovascular disease after. 8 to 10 generally not indicated, but those with symptomatic anemia, ongoing bleeding, etc. More than 10 not indicated. Consider clinical scenes and judge. The best is prevent by deworming, oral iron, antinatally. Get the hemoglobin to 12 at pregnancy. Pre-autologous deposit is not recommended. We cannot, like other surgeries, we cannot take the blood and give after nothing. Cell salvage can be done. PRCs in cases with antibodies, cytomegalovirus seronegative red cells should be provided. Leukodepleted also can be used. Always communicate with transfusion specialist because usually we don't talk anemia. We talk to the blood bank medical officer. What is available? What is to be given like this? Sickling thalassemias are separate entities, but avoidance of hypoxemia, hypovolemia, hypothermia, acidosis is important. More than 8 HbA because I used to do this anemia profile in these patients in one of the labs. This anemia profile contains everything, B12 level, folic acid level, vitamin D level, everything. So peripheral smear, hemoglobin electrophoresis, all these things come in one package. So I do this to many patients. So we can have an overall idea of transferrin, ferritin, everything is coming in that. Thalassemias are a different group of microcytic hemolytic anemias. Chronic anemia with iron overload for the heart and a difficult airway. We all know thalassemia is a difficult airway. So definition, qualitative and quantitative reduction of hemoglobin. So that the oxygen content is not there. There is not enough supply to the vital organs and tissues. Usually considered less than 10. There may be some variations in first trimester or third trimester. What is the incidence? We have found out 46.8% incidence. So many classifications are there: mild, moderate, severe, very severe, preferably around more than 10, 7, 8, 9, 6 or below. These are the basic classifications. If you have anemia, the blood viscosity will decrease, cardiac output will increase. If it increases more than, that's what I told. Anemia and pregnancy, anemia and cardiovascular system, pregnancy and serious. All these things go with each other and worsen. Pre-op optimization. And what are the goals? Good oxygenation, rapid sequence induction if you are considering GA, good pre-oxygenation, good FiO2, and prevent good temperature, prevent hypothermia, shivering. So all these things, good analgesia, post-operative pain relief, and continue to give oxygen in the post-operative period. Invasive lines are only indicated where there is a decompensated anemia, especially with placenta previa, creta, all these things. Good analgesia, sufficient oxygenation, and no shivering. These are the three essences of post-op care.